Well, thank you very much.
Presented by Thomas Forbes.
Sure. Thank you very much. And my pleasure today to present some of the work performed by Dr. Mohammad Hussain, who's one of our vascular surgery residents and PhD students. So we've updated the title from what's in your program because this follow-up is now extended to 13 years. So no disclosures. As a background, we know that RCTs recently have suggested CAS to be non-inferior to endarterectomy. There continues to exist some controversy around the external validity of these trials, as they may be limited by operator and institutional selection bias and the inclusion criteria of the study itself. And there's really a paucity of high-quality, long-term data that exists on the outcomes of endarterectomy and carotid stenting on a population or real-world level. So the objective of this study was to compare the long-term, up to 13-year outcomes of patients treated with endarterectomy or stenting in the context of increased uptake of stenting in our province of Ontario since 2005. So the study design is a retrospective population-based cohort study beginning in 2002 and with follow-up to 2015. Population of Ontario is 13.5 million, single-payer health system, so we're able to link different Ontario health administrative databases. The coding was validated for endarterectomy and for stenting, as well as the outcome measures in a separate study. And the purpose of this study is purpose of this talk is to discuss the propensity score matched analysis. There was also a multivariable analysis, but I'll only present the propensity score analysis. And each stenting patient was matched to 2 endarterectomy patients based on the number of covariates. So looking at the results, the overall cohort was over 15,000 patients. The cohort that we're going to discuss today was just over 6,000 patients, with over 2,000 patients who had a carotid stent matched to at least 2 endarterectomy patients. The matching was successful. When we look at the baseline characteristics, there was no difference in the patients who underwent endarterectomy or stenting. Similar ages, 2/3 were male, just over 50% were treated for symptomatic lesions. They had similar comorbidity scores and incidences of coronary artery disease, congestive heart failure, COPD. The vast majority were primary procedures, so very few had had a prior endarterectomy, and close to half were urgently admitted. So this is the summary slide of the primary outcome variable. And the primary outcome was a combination, it was a composite outcome, a combination of the complications of carotid procedures, namely 30-day MI plus or minus death, and any stroke up until 30 days. So included the 30-day period, but up until 13 years. In the risk-adjusted cohort, the incidence of this outcome variable was 16% in the stenting group, just under 10% in the endarterectomy group, and the propensity-matched group showed 16% in the stenting group and just over 11% in the endarterectomy group. Looking at the Kaplan-Meier curve, there was immediate divergence of the curves in the first 13 days, representing an increased risk of MI or death in the stenting group, and then the curves continue to diverge for the remainder of the study, representing increased stroke rates in the stenting group. Stroke and death outcomes, the 13-year risk of stroke and stents was in the stented patients were 13%, 9% in the endarterectomy group, higher risk of stroke at 30 days in the stents. All outcome variables were higher in the stent group, including stroke beyond 30 days, 13-year death rate, death less than 30 days, and death beyond 30 days. When you looked at some subgroup analysis, particularly, and some of them I'll highlight here, age, the results remained robust in favor of endarterectomy, regardless of the patient age, regardless of the patient's sex, regardless of the date of the procedure. The results remained consistent, and they also remained consistent when considering the symptomatic status of the patient, whether they were asymptomatic or symptomatic, as well as the diabetic status. So in summary, carotid stenting was associated with an early and sustained 30 to 50% higher risk of long-term stroke and death. These differences were driven by increased risks of stroke and death within 30 days, and after 30 days, risk of death with stenting. This was observed regardless of age, sex, carotid artery symptoms, year of procedure, or diabetic history. Raises some questions about the generalizability of these RCTs to clinical practice, at least in our jurisdiction. A subgroup analysis, and not the topic of this discussion, was also that the lowest rates of endarterectomy adverse outcomes were in procedures performed by vascular surgeons, and these were the funding bodies. So thank you very much.